Hello, everybody. Happy Thursday. Good afternoon or good evening, depending on where you are in the world. Thanks for joining us tonight. We're really excited. This is our Answers from the Experts live program. So I'm going to go ahead and start sharing my screen for just a very brief PowerPoint. So welcome. First, we like to start out and thank our corporate partners and our individual donors. Thank you for making these programs possible for us. Tonight we have two wonderful speakers. We have Dr. Brad Haverkos with the University of Colorado Anschutz Medical Campus. Dr. Haverkos is an assistant professor of medicine hematology at the University of Colorado. His research focuses on developing novel management and treatment strategies in aggressive lymphoma subtypes with a focus on mature T and NK cell lymphoproliferative disorders, including T-cell lymphomas. So thanks for being here, Dr. Haverkos.
Pleasure.
And we also have Dr. Jasmine Zain with the City of Hope National Medical Center. Dr. Zain is an associate clinical professor in the Department of Hematology and Hematopoietic, sorry, I always say that word wrong, cell transplantation. Additionally, she is the Tim Nesvig Lymphoma Research Fellow, as well as director of the T-cell lymphoma program at the Tony Stevenson Lymphoma Center at City of Hope. Thank you for being here tonight, Dr. Zain.
Thank you. You're welcome.
So the way this is going to work tonight, if you haven't joined us before for one of these, it's a very informal Q&A. And so I'm going to go ahead and allow the open questions here. So if you have any questions on the show, you can just open up the little box at the bottom of your screen where it says Q&A, type in your question there, and then I will ask it aloud as the time allows. So we only have an hour tonight, so we'll go ahead and get started. Sorry, I have a million screens open here. So the first question we have is, what over-the-counter and prescribed cream do people use, especially for the itch? Maybe Dr. Zain, do you want to start with this one?
Sure. So I want to clarify, first of all, that both me and Dr. Haverkos are actually hematologists, or in some places, we go by hematologist oncologists. We really prescribe mostly chemotherapy and systemic therapies, but I will take a shot at this question. I do work with dermatology colleagues, and I know that over the counter, they like any kind of an ointment or cream that does not have any kind of scent in it, because I think that creates more allergies and maybe some irritation. One of the favorite brands for my dermatologists, that I work with in the cutaneous lymphoma clinics is CeraVe. The CeraVe ointment. There's a blue jar, which is a thick ointment. And, sometimes if you have very dry skin, especially if you're undergoing treatments like light therapy and things like that, it's very useful to use it in areas of very dry skin. It is very thick to apply. And there is also a white jar, which is a cream, which is very helpful. And I think they have one with a pump dispenser. So that's over the counter. In terms of prescribed medications, we use a lot of steroid-based creams to help with the itching. They come in different strengths. For areas of your face, you could use hydrocortisone, that's over the counter almost. And then for more extensive areas, we sometimes recommend a stronger steroid like triamcinolone is my favorite. It's 0.1% is prescribed, and you can get a whole jar of it. So that's my recommendation. I don't know if you had anything to add, Dr. Haverkos.
No, I agree with all of that. I think sometimes for a little bit more difficult to treat spots, we might use a stronger steroid like clobetasol.
Right.
That's one that we tend to use a little bit more sparingly and not apply it for long durations of time to real sensitive areas of skin or like the face where it's real thin, because sometimes you can have long-term issues with stronger topical steroids. So.
Right.
And then I guess the other things to add would be some of the topical chemo drugs like Valchlor. Sometimes we use topical retinoids. Those are things that we also use sometimes. Certainly, those are prescribed topicals, but are useful a lot of times as an adjunct to some other therapy. But are good options to treat, especially earlier stage cutaneous T-cell lymphoma.
Great. Thank you.
Yeah.
So this one, I am 69 and have the Sezary Syndrome since 2012. Now I am on vorinostat. The number of the Sezary cells in clinical blood tests is from 63 to 35%. I wonder if there's any information of the use of immune therapy in my case. Keytruda is widely used in Russia in oncology treatment, but not in cutaneous lymphoma. I also have the necessary 42 vials of, is it Poteligeo?
Poteligeo, yeah.
Ligo, but still hesitant to use it due to possible severe after effects. Thank you in advance. Dr. Haverkos, do you want to take a stab at this one?
Yeah, sure. I guess maybe the starting point to this with Sezary syndrome. Sezary syndrome implies there's sort of a higher degree of blood burden, which really requires looking at the absolute number of Sezary cells, not just the percent. So sometimes, percent of Sezary cells is usually based on flow cytometry, and if the total number of cells there is relatively small, even if the percent's kind of high, it could be a relatively low number of cells. But assuming that you have kind of higher burden of blood involvement, we do tend to use certain therapies more often, or at least I do, in patients with blood involvement than patients that don't have blood involvement. And we definitely think about the mogamulizumab as a really good drug for that patient subset. And we've seen, I've in the clinical trial and personally, I've seen really nice responses in patients with high blood involvement and low blood involvement with mogamulizumab. I know that the question too was a little bit about side effects from the mogamulizumab. I mean, there are certainly risks of any therapy in it, but I think mogamulizumab in comparison to some other therapies is relatively mild, and there are certainly side effects that are, at least I've found, very manageable, and no real significant long-term side effects that can't be overcome by really just stopping the drug or potentially using steroids in some of the more severe cases.
Correct.
So I don't know if Dr. Zain has more to add to that.
No, that's exactly, and that's exactly what the Poteligeo that you're referring to is the mogamulizumab that Dr. Haverkos was talking about. I actually agree with you. I think the side effect profile of Poteligeo or mogamulizumab is actually quite mild. And in my practice, I see that the Sezary count goes down pretty quickly, and the rash and the redness gets better almost within 1 to 2 cycles. And there is this concern about the skin rash that can occur later on, and that we've managed with just stopping the drug or giving some steroids. It's very easily manageable, and so the side effects are great. The second part, I think the first part of the question was regarding pembrolizumab, and again, that has been it's used in many different types of cancers. But its use in T-cell lymphomas has been a little bit controversial, but there is a study from Stanford that looked at patients with skin lymphomas, and I think it included some Sezary patients as well, and the response rate was reasonable. It was about 37%. Again, it's not widely used to treat Sezary syndrome. I would actually, if I had a choice, I would go with Poteligeo before I use pembrolizumab. And the side effects there are also not trivial. If you have them, you can have pneumonia, diarrhea, thyroid dysfunction. So I think Poteligeo is definitely safer than Pembro at this point, and maybe even more efficacious.
Yep. No, I certainly would agree, especially for the patients with blood involvement, that it's a really nice drug, and the Keytruda or pembrolizumab definitely still has some of the same side effects of you can get a rash after starting the drug. So I think that if given the choice for a patient with blood involvement of pembrolizumab or the mogamulizumab, I think that the mogamulizumab would be my choice as well. So.
Good.
Thank you both. Is there any known link or correlation between LYP and developing small fiber neuropathy?
Small fiber neuropathy. You want to take a stab at that? I think my answer would be I don't know or no.
That's a new one for me as well. I haven't heard of that, so I guess I'd have to say I don't know or no.
Yeah. Yeah.
Fair enough.
Yeah.
Let's see. What should CTCL patients be aware of with respect to COVID vaccines? Everybody wants to
Hmm.
hear more about this one.
Sure.
So I don't know if you're able to give us an answer, but
I can try, and I'll have Dr. Haverkos also chime in later. I mean,
Yeah.
I think the COVID-19 vaccine, we first of all, we don't know. That's the big answer. However, and the reason for that is that none of the cutaneous lymphoma patients were included in the trials of vaccine. As you know, the trials were done pretty, over the last 6 to 8 months. It's an emergency approval of the vaccine. Given the severity of the pandemic, it had been difficult to get every patient represented in the trial. Having said that, of course, it's a very practical consideration for everybody to see if they can get vaccinated. And at the moment, I think we don't know of any specific contraindications in patients with cutaneous lymphomas, even those undergoing therapies who should not get the vaccine. We do know that patients who've had a bone marrow transplant, that maybe within 6 months of having their transplant, the vaccine may not be as effective. And secondly, I think if you're getting CAR T cell therapy, again, that's not a therapy that's used for patients in mycosis fungoides, unless you're in a research study. It's recommended not within 3 months of CAR T cell therapy. But otherwise, I don't think I know of any treatment that would be cause a problem in patients with cutaneous lymphoma. The only issue is that they may not mount a response that's as robust as if you were a normal, healthy person. So, and that degree, how much of that response is going to be is very difficult to measure. We are hoping to do some studies. I think different centers are getting together to look at this question of how robust is the response after the vaccine, but I can't think of any specific contraindications.
Yeah, no, I
And I'll
think,
ask.
yeah, I mean, I obviously, again, I guess starting out that we don't have a lot of data,
Yeah.
um, other than just sort of our anecdotal experiences with giving COVID-19 vaccine in the setting of cutaneous T-cell lymphoma. So I usually tell people that in general, I think that it's safe. There doesn't really seem to be any kind of reason that I can think of that would make it unsafe to get. And I think the question for most of the time is if someone is on some sort of immune suppressive therapy, how good of an immune response they can mount. Um, I have a couple of patients on drugs that sort of immune stimulatory or modulatory drugs like interferon, and I haven't seen any. I think in that subset of patients, I maybe at least think that there might be more of a immune reaction to the vaccine, which could in some ways be a good thing. You have a better immune response, but I haven't seen any more severe reactions in the small number of patients that I've given to that are getting interferon um, or like photophoresis. But I think we'll obviously be collecting more data, and Dr. Zain sounds like she's involved in a study that's looking at trying to get a lot of patients together. So I'm not sure if you have any comments on that, Dr. Zain.
No, not at the moment. I think time will tell, but I think getting COVID, I look at it, and that's what I counsel my patient. Getting COVID is a lot worse than any possible side effects from the vaccine. So
Yeah,
I think we need to use that information and just be careful. Talk to your doctor. Make sure they know that you're getting the vaccine. So in case there are any complications, they can take care of it. And just be very vigilant and let us know how it goes.
yeah,
So
absolutely. Yeah, absolutely. If there's issues, I think
yeah,
letting your doc know and so that we can kind of
yeah,
put this information out there.
yeah.
absolutely. And just to highlight the point, always talk to your doctor. We can't
Yeah,
give
exactly.
personal medical advice on here, so it's just always a good idea to consult your
Yeah.
doctor for your individual needs.
Yep.
Um,
Right.
so I have been told after my second biopsy that I have non-aggressive MF. I have had it for over 26 years and told I would likely die with it, not of it. Can I safely assume that my MF would not likely become a more aggressive form?
Um, okay.
Uh, I guess
Brad, that's
I'll
that's
yeah, I'll
yours.
start. um, I mean, I think we'd all love to say that we have 100%, guarantee that it's not going to transform into a more aggressive disease. I think can't give that guarantee, but I think that most patients that have indolent disease in general, and most patients um, that have early stage disease, do die from something else, and the disease is very manageable. I think that um, if you are working with your dermatologist or oncologist and are able to keep control of the disease and are managing it, I think that will minimize probably the chances that it would get out of control or become more aggressive to the point where you can't or it becomes an issue or life threatening.
Right.
Let's see. I have been using methotrexate for 4 years. I stopped it once and it was not pretty. Your thoughts on how long to stay on it?
Okay. I can take that one. So basically, I mean, methotrexate, I don't know what dose you're taking. So that's the first question. Generally, for cutaneous lymphomas, we use the once a week oral dosing, but there are other ways that doctors give it another way. It can even be given intravenously. The main issue with the long-term use of methotrexate is liver toxicity because it does cause liver damage in the long run, and there is some cumulative effect. I think your doctor should keep an eye on your liver functions and see if there's any evidence of damage. It is not recommended that you go on and on methotrexate. I'm after maybe 1 or 2 years, I tried to switch the patients over to something else. Um, if possible, just because there is this concern about liver toxicity in the long run. Um, so that's something to be careful about and talk to your doctor about.
Yeah, I think we always try to kind of balance and minimize the amount of drug that's needed to control the disease. And so it's always trying to weigh the benefits of continuing the drug versus decreasing the drug and risks of it versus switching to other therapies. And I mean, unfortunately, everybody's disease is a little bit unique, and so everybody has different unique situations. So it always we can always answer these questions by saying kind of it depends on the individual,
Yeah.
but I think something that we all try to do is minimize the amount of therapy or dose of therapy while controlling the disease as best we can.
Hmm.
Let's see. I'd like to know if there are any treatments that can be used for stage 4 transform Sezary syndrome beyond the standard treatments. Are there any drugs or other treatments on the horizon that could be promising?
I guess I can start. So,
Sure.
there are certainly drugs to consider, both FDA-approved drugs as well as other drugs that we would use. I don't want to get too far down kind of the rabbit hole into specific drugs, I guess, that are FDA approved, but there are lots of, depending on your situation, drugs like brentuximab that might target CD30, or mogamulizumab, like we were discussing before, are drugs that you can consider depending on your clinical scenario. But there are, outside of the FDA approved drugs, there are lots of exciting clinical trials, and we both just attended our annual meeting. There are sort of different, a lot of combination studies out there. We're trying to take two different drugs, both that work, and see if they have synergy together and work better together, especially for these really challenging, difficult to treat scenarios. There are certain drugs like kind of that inhibit certain pathways that the cancer cells might use. Class of drugs called PI3 kinase inhibitors, that is kind of up and coming. There's immunotherapeutic drugs like the Keytruda that was mentioned before, and then other different combinations of drugs that currently exist, and other things like CAR T that was brought up briefly by Dr. Zain. I think we're still a little bit probably away from having that, but certainly something that is in clinical trials and being investigated.
Yeah, I mean, I've treated my first patient with the CAR T, a cutaneous lymphoma patient with CAR T. We'll see how that goes. And I think 2021, the following year, we'll see a lot of CAR T trials in T cell lymphomas, and especially skin lymphomas, and also a lot of new antibody studies that are coming through that target the immune cells, target the cancer cells in the T cell lymphoma in the skin, and also bring in your immune system to try to fight them. You know, kill the cancer cells. Those are called bispecific antibodies, and there's a couple of them in trials right now that look promising. So there are a lot of new treatments coming down the line. And there's always allogeneic stem cell transplant, which is, for a very advanced patients, that's another option.
Mm-hmm.
Yep. Yeah, always for people that don't know, you can always look on clinicaltrials.gov for clinical
Right.
trials that would be applicable. You can type in cutaneous T cell lymphoma and look up enrolling trials, soon to open trials, etc. It's a good resource that I think definitely patients can use.
Sure.
Let's see. Does methotrexate or other systemic medications improve prognosis?
That's
Want to take this one?
sure. So that's a difficult question to answer because prognosis is determined a little bit by your stage as well. So, patients who have advanced stage disease definitely have worse prognosis than people who have early stage disease. And, as I mentioned, methotrexate can be given you can give there's a many different dosing strategies to give methotrexate and other treatments sometimes. In particular, methotrexate is usually used for disease that's not very aggressive because we want to use it for a long period of time. It's given orally, and usually those patients generally have a good prognosis to start with. Really, the poor prognosis patients in cutaneous lymphoma are the ones that have tumors or have transformation or have disease involvement beyond the skin. We also say, or used to say, I use that with caution, that Sezary syndrome has a slightly worse prognosis than non-Sezary patients, but I think that is changing because we have better therapies for Sezary syndrome right now. So the question of prognosis is very difficult to answer. It is very difficult to answer if any strategy improves, prognosis in early stage disease. It's hard to say. I don't know what your thoughts are, Dr. Haverkos.
Yeah, I mean, I think we don't really have good data. I think just in general, I think that it's always it seems like a good idea or good practice to just keep, if your disease is under good control, that probably is a good thing in the long
Yeah.
run, and that the more out of less control your disease is, probably more likelihood that something that it's just going to be harder to rein in with therapies, and that maybe that it could transform. So I think it's we don't have really good data, but I think in general, or just anecdotally, it seems wise just to try to control your disease as well as you can and work with your local docs there.
Let's see. When would it be recommended to have a flow cytometry test?
Okay.
Or Dr. Zain?
All right.
Dr. Haverkos can start.
Yeah. So I think there's a lot of different differences of opinions on who should get flow cytometry sent, and some of these other more more advanced testing too, molecular testing, things where we look for very minimal amounts of the cancer cells in blood. So I think, for me, I usually check once on everyone. But I think for early stage patients, it's not always necessary to check flow. But I usually check once. And I think certainly the patients that you definitely should check it on are people that have obvious abnormalities in their white blood cell count, where you would think they would have Sezary syndrome, or people that have kind of a phenotype consistent with Sezary syndrome where they're erythrodermic, so red kind of all over. Those are sort of two populations that I think probably most people would agree it should be sent on. But
Yeah.
I think early stage patients, we tend to do it at least once, and then tend to do it when people if they're progressing past skin-directed therapies. But I think that there's some debate on who should get it.
Yeah, I agree. So I also get it once on all patients at a baseline. And then if they progress, have abnormalities of their blood count, or if they have generalized redness or itching, erythrodermic patients. Yeah.
This person is a 54-year-old female. She was diagnosed in 2013 with MF stage 2, initially treated with Puva, Kenalog, topical steroids 3 times, targeted radiation treatments, switched to interferon since 2016 with 90% of efficacy. However, Merck is discontinuing interferon in May of 2021.
Mm.
She would like to know if you have any guidance on how to safely taper off of interferon A.
Yeah,
Mm.
that's a tough one too, because I think it's a challenge that a lot of us are
Facing it. Yeah.
facing. I think that I know that some of the consortiums and Cutaneous Lymphoma Foundation, people are trying to see if there's something that we can do at a higher level to make sure this drug doesn't go away. But
Right.
in the absence of that, there is a pegylated form of interferon that we use. So it's once weekly dosing that I've switched a lot of patients over to. It's a little bit unclear to me if it's has the same efficacy or not, but it can work. I can say that. So we've switched to that pegylated once a week version in most patients.
Okay. Yeah, she had a second follow-up question. What other treatment options might be available now for controlling symptoms and managing disease? And she is in Canada.
Oh,
So
yeah, I
I'm
don't
not
know,
sure
but I'm not
that's
sure.
one. Yeah.
I'm not sure about the pegylated version in Canada. And the one thing that's difficult, or that we've run into, and I don't know if you have as well, Dr. Zain, but the pegylated version, there's a little bit less dosing sort of
Side.
ability to dose, just because
Mhm.
it's kind of limited in terms of how it's packaged,
Sure.
and so I think you can't go down to lower doses that you might have gone down with the shorter acting interferon, and you can't titrate quite as tightly of a
Right.
dose.
Right.
But
But there's other treatments, a lot of new treatments have come around. I mean, seems like you've only used some light therapy and some topical treatments, and this is the first. Did she use bexarotene already?
oh yeah,
Yeah. So
therapy.
there's other treatments that are, sort of equivalent or similar to interferon. Not the same mechanism of action, but can be used for similar stages of disease, and that's bexarotene. You can also have some, as I mentioned, there's some new trials coming. Eventually, they'll be approved, so it'll be, so there are other options as well.
Yeah, and I think the person the she could maybe have some comfort even if she does have to go off interferon. That I think it's fairly common practice that we'll switch therapies for any variety of reasons, whether that be progression or cost of
Yeah.
medication
Right.
or et cetera. And there fortunately are several other options. And if her disease is under good control
Yeah.
as it is, it makes it probably a bit easier to switch to something else and figure out what might work for her.
Okay.
Sure.
Let's see. I know these COVID ones are kind of tough. We have a lot of people interested in this topic,
Sure.
obviously. Do patients with CTCL have additional recovery issues if they become infected with COVID? I don't know if you can even answer this one or any
Um,
little insight. Maybe
I,
not enough information.
I guess I
uh,
guess it just depends on the patient, in the scenario. Like it was mentioned, brought up before, if you had a bone marrow transplant, for example, for your cutaneous T-cell lymphoma, that's a very different situation than someone who's, just on targetin or on light therapy. Very sort of different risks to getting COVID in those two scenarios. So I think depending on what therapy you're getting and sort of what stage of cutaneous T-cell lymphoma you might have, really impacts probably your risks associated with COVID.
right. I mean, I think I've had one patient who developed COVID, was asymptomatic out in the community with T-cell lymphoma. This was not cutaneous T-cell lymphoma. So, I mean, I think it's variable about how your immune system reacts to the virus and how sick you get. Um, It also depends on what kind of therapy you're getting.
Okay.
I mean, the disease per se, I don't think we know if there's an added risk just because you have mycosis fungoides.
Mhm.
But
Yeah.
we don't know the answer to that. Yeah.
One more COVID question. What are your recommendations for B cell patients regarding care with Rituxan during
Ah,
COVID-19, vaccinate or not?
yeah, so that's actually come up quite a bit, and we do have a recommendation for that.
Great.
And this is coming again from, I believe it's coming from the, the BMT guidelines, as well as some of the hematologists that have gotten together. Rituximab in particular, and other CD20 directed antibody therapies for B cell, B as in boy lymphomas, target B cells that are important for making antibodies against vaccines. So it is recommended that if you're getting rituximab, that you not be vaccinated within 3 months of that therapy. In fact, we are stopping people's therapies with rituximab. We're on maintenance type of regimens to allow them to get the vaccine, because the benefit of rituximab maintenance is not that great, and the risk of getting a bad COVID infection is far outweighs that. So rituximab, Gazyva, ofatumumab, all of these CD20 directed therapies, we're recommending not, a 3-month interval between the treatment and the vaccine.
Thank you. CTCL and CA large cell lymphoma, is there a difference in prognosis with these two together? 30 CD30 positive proliferative. Please explain the three pieces of information in more detail.
Not certain of the whole question, but I can maybe piece apart answer some of the
Okay.
questions, I guess, that I think are
Maybe we
in
start
there.
with
Yeah.
CTCL and CA large cell lymphoma. Is there a difference in prognosis with these two together?
It may be the large cell transformation, what they're talking about.
Okay.
And maybe, I don't know. Okay.
Yeah, and then they added CTCL, CALCL, and then CD30 positive proliferative regarding prognosis. Does that help?
Yeah, so I think they're talking about anaplastic large cell lymphoma and CD30 positive lymphoproliferative disorder, this whole spectrum that we all have a lot of confusion around, even as physicians. These are all, so there are patients who can have LYP or CD30 positive lymphoproliferative disorders in their skin, which is a spectrum of diseases. On the other end of the spectrum is this large cell, what could be called large cell lymphoma, but it's actually anaplastic large cell lymphoma arising in the skin. And anaplastic large cell lymphoma can arise in the skin, or it can arise inside the body. And most of the time in skin patients, we're really dealing with this differential between either LYP or a CD30 positive lymphoproliferative disorder or anaplastic large cell lymphoma. If the lymphoma is confined to the skin, even with large cell transformation, the prognosis remains good.
Mhm.
If it goes inside the body or arises inside the body, called systemic anaplastic large cell lymphoma, that's the one that has a worse prognosis compared to a skin lymphoma patient. So I don't know if you wanted to add to that, Dr.
Yeah, no, I think
Haverkos.
those are all perfect points. I think if when we see someone with a skin biopsy that shows large cell transformation, it doesn't necessarily mean that they'll do worse. I think sometimes I tend to keep a little bit closer eye on them initially, just to make sure that their disease doesn't progress, in their lymph nodes or viscerally or sort of more aggressively in their skin. But you certainly can have a large cell transformation in the skin and still do very well and not have a poor outcome. I think
Mm-hmm.
there was a mention in there about CD30 as well. Not all large cell transformation is CD30 positive. Some of it is, but we certainly use CD30 as is sometimes a marker that at least can be useful to help us tell whether a drug called brentuximab might be the right choice for you. Now, just because you're CD30 doesn't necessarily mean that you should always get brentuximab, but I think if it's there, that might, depending on what your other options are, it may be something that we would think about using.
Okay.
Thank you. Hello, I was just recently diagnosed, but I have had it since 2007. I don't have any blood or organs affected. How do you keep it from going to blood or organs?
Did she say what she's diagnosed with?
She didn't.
Oh.
If you are able to
Well,
clarify, you can add it to the chat or the Q&A. Is there a, oh, she said MF.
okay. So there, if it's confined to the skin, most of the time it stays in the skin. The risk of it going into your blood or your organs is very, very low, but only time will tell. Most people who progress rapidly with this disease do so early on in the disease, and you would know within a few, I say tell my patients within 1 to 2 years if this is going to behave more aggressively. Most of the time it stays pretty indolent. Unfortunately, we don't have any ways to prevent it from becoming more aggressive because we just don't have any therapies to, at the moment, or any even a marker to say who is going to progress and who is not. So at this point, unfortunately, it's just observation and having close contact with your doctor.
Okay. Let's see. Sometimes my white count is low. I still do not understand what that means with CTCL and why it will be normal sometimes. Dr. Haverkos, you want to try that one?
Yeah, I guess if this is someone that's just on skin-directed therapy and not on any kind of systemic therapy, it might just be sort of a normal variant. Some people live with a little bit lower white count and they don't get infections. It's not an issue. Um, if it's mildly low and they're on any number of systemic therapies, it might be because of the systemic therapy. But usually if it's not significantly low, we don't get too worried about risk of infection. And it's always too about balancing the benefits of the medication and risks of stopping the medication and what your alternatives are.
Mm-hmm.
If it's due to the medication, that is.
Sure.
Let's see. This is a tough one. I was a firefighter. Did exposure to chemicals make this worse? I don't know if you can even answer that one.
Okay, so there is, depends on the first of all, we don't really know. There's no way to really establish that. There are certain chemicals, certain hydrocarbons and petrochemicals that are associated with an increased risk of lymphoma in general. But whether that's something in firefighting chemicals, I don't know for sure. It also depends on your degree of exposure. So even with the known sort of hydrocarbons and petrochemicals, the exposure has to be prolonged for several years. That manifests itself as a malignancy many years later, usually 10 to 15 years later. So it really depends on what you were exposed to and for how long. But again, there's no real way to actually say for sure. It would just be a guess at best.
Yeah, it's always tricky. People always want to
Yeah,
know what caused this, and
yeah. Mm.
If only
it's
we
really
knew.
hard to know.
Yeah,
We don't know vast majority of the time, unfortunately.
yeah, yeah.
But
Let's see. I have MF stage 1B diagnosed for the past 4 years. I have had 2 stubborn plaques that aren't currently responsive to UVB and cortisone ointments. My local derm suggested injecting with Kenalog. I wonder what your
Mhm.
opinion of injecting a stubborn plaque is for the long term. Um, and then she added, and like the last question, I wonder if this means that I'm not progressing to a more aggressive form.
I guess
I
I could
mean,
start. Or
sure,
um,
sure.
so the latter part of the question, I guess, is maybe easier, I guess, for me to answer. I wouldn't say just because you have a stubborn plaque that in any way it's transforming or becoming more aggressive.
Right.
It's kind of a stubborn plaque. And neither of us are dermatologists, but thinking about a more potent steroid or injecting with steroid seems fine from my standpoint. Or even sometimes we'll use more potent topicals like Valcor, a tartretin gel, or even low dose radiation would probably get rid of the plaque as well. So I think these are all things that could be considered depending on your particular scenario.
Right. I
Um,
agree.
let's see. Another Merck question. Tell us about this new drug, Valclor. Is it more effective than systemic treatment with immunosuppressive therapy like Cellcept for early stage mycosis fungoides?
Okay, so Valchlor is a topical nitrogen mustard. It's a chemotherapy. Nitrogen mustard is actually one of our oldest chemotherapies known to mankind, but it's a topical version, and it's not new. It's just that the Valchlor is now a new formulation. It has been used. We used to compound it with petroleum jelly many years ago and give it to patients, but it was very cumbersome. So Valchlor has made it easy for patients to apply. It is effective for for early stage disease. It can be applied topically up to 3 to 5 times a week on lesions once a day. There are some precautions with it that you have to take, and there is some skin irritation. Whether it's more effective than Cellcept. Now, systemic therapies like Cellcept, I mean, I don't know. I don't use Cellcept a lot. Do you, Dr. Haverkos, for treating cutaneous
No,
lymphomas? Yeah,
yeah, not really.
yeah, they are therapies that are very immunosuppressive, and they are designed to basically kill T cells, and they're usually used in the world of bone marrow or organ transplant to suppress the immune response. I guess because they suppress T cells, you could theoretically use them for T cell lymphomas as well. Whether they're less or more effective is very hard to say, but I think there's more toxicity associated with Cellcept as opposed to topical Valchlor. So if there was a choice and there was early stage disease, I would probably use the topical Valchlor before moving on to something systemic.
Okay.
Yeah, yeah, I agree. We don't use Cellcept really if it's purely just a cutaneous T cell lymphoma. I can't recall using Cellcept. I think there's some cases, other dermatologic conditions that might coexist with cutaneous T cell lymphoma. There might be
Right.
some indications there to use Cellcept, and so I've seen it. I've seen patients come to me on Cellcept, and then we diagnose them with cutaneous T cell lymphoma and change therapy.
Right.
But
Right.
it's not one that we usually reach to, just because we have other usually better
Other,
options.
right.
What criteria is used to determine if cutaneous lymphoma is controlled? Thank you.
Um, So I think the best way is to just see the skin because it's a skin disease. You can visualize the tumors. You don't need any special scans or anything. So there is, just visual inspection to make sure that the skin is looking normal. Sometimes lesions will heal, and especially if there's melatonin in the skin, they heal with decrease or more pigmentation. So the skin may become darker in that area or may become lighter. That if the skin is flat, it doesn't feel like there's anything and is otherwise feeling normal, then we consider that a good response and we can say it's cleared. The absolute measure would be to do a skin biopsy to show that there's no more lymphoma cells. But of course, you can't biopsy the whole skin of a person. But visually, if it seems normal, there are no plaques, there's no raised lesions, the skin appears and seems normal. Other than the pigmentation change, sometimes we can call it a complete response. If there's lymph node involvement or blood involvement, we need to check that as well to ensure that those compartments have also cleared of disease.
Yep, yep, all great points. I think we don't routinely, or at least at least I don't routinely, get CT scans or repeat
No,
imaging unless
yeah,
unless for some reason we're concerned that someone,
right.
clinically is developing lymph node involvement or more aggressive disease based
Mm-hmm.
on their skin exam. Or if they've had lymph node involvement in the past, we would check to make sure that that's getting better. But I don't think most people would not routinely get serial CT scans for cutaneous T cell lymphoma.
Okay. This one, my husband was diagnosed with transformed MF as one of the patches had a CD30 expression. All the tests he had done, such as a PET scan, bone marrow, bloods, came back clear, and the patch mentioned went away spontaneously. His
Ah,
hematologist, his hematologist recommends a radiotherapy to put the lid on the patch that he had a
mm-hmm.
CD30 expression on. Would that be a standard approach? And then she added, let me just say my husband is at the moment patch free as per his dermatologist. Let me know if you need me to repeat it.
Okay.
That was a long one.
No, I mean, there's a thing called, so CD30 expression, as Dr. Haverkos had mentioned earlier, does not always mean something bad. It's something you can see sometimes in these T cell lymphomas, they express it. We see them more often in transformed disease, but you can also see them in patches and plaques. I think one aspect of CD30 positive skin lymphomas is something called LYP, lymphomatoid papulosis, which has the only, it looks like a T-cell lymphoma under the skin, but it has the clinical characteristic of waxing and waning. These lesions go away by themselves. And that is the best test for this condition. It doesn't require any treatment unless it becomes, they become just too much. So at this point, I would suggest not to do anything if there's no plaques left and there's just for a few cells that are CD30 positive, I wouldn't do anything, especially if they've disappeared. It might just be some element of LYP that's getting better
Yep,
on its own.
definitely agree.
Awesome.
Okay.
Let's see. I have ALCL and CTCL. I was just taken off of methotrexate. I'm getting new lesions where I have had radiation adjacent to, and after 3 weeks off of methotrexate, is this concerning? Added, I have had multiple lesions of this ALCL in my arm and on my ear.
Yeah. I guess I'll start. So we we've had, we have a number of patients that have both, mycosis fungoides and like LYP and anaplastic large cell lymphoma. And I think some of these patients with LYP are very sensitive to methotrexate, or patients with kind of primary cutaneous CD30 positive cutaneous T-cell, cutaneous lymphoproliferative disorders. And I find that, you take them off methotrexate even when they're on very low doses and they break out with lots of lesions, which sounds like the scenario for this person. So in those cases, we always try to, we put them back on methotrexate to probably get rid of, to see if they respond again. And then try to, if the goal is to get off therapy or get on as minimal a dose, try to titrate down very, very slowly, over time. Sometimes we use light therapy or if that hasn't been used, could be something to consider as well as a sort of strategy to wean from methotrexate over time, but there's probably no rush emergency to do so.
Right. But if it's ALCL lesions, maybe using brentuximab may be an option. And there was just an abstract, I'm sure you saw it, where they use a lower dose on a weekly basis for these patients. Maybe something to discuss with your doctor.
Yep. Yeah, that's a good option as well too.
Yeah.
Thanks.
Let's see. My husband is a Sezary Syndrome patient with LCT. He had a mini allo transplant in 2014. He is CD30 negative. Since SCT, he has had Valchlor, flash tile, Targretin, then diagnosed with LCT about a year ago. He tried Doxil, Moga, GDP, ICE, and he has had several LCT tumors radiated on his head. He's just flunked a trial, lenalidomide 5.
Azacitidine.
Yes, thank you.
Romidepsin and dexamethasone. Yeah.
Yep, thank you. Is duvelisib a reasonable next step? Can it be used outside of a trial with another drug, or would you recommend something different?
I can take that one.
Okay.
So duvelisib, again, these are still clinical trials. We don't know if they will work in in every patient. Certainly, there is a lot of activity seen in duvelisib or other PI3 kinase inhibitors of this class of agent. That seems to be an exciting agent in this disease. At this point, I do know that you can get duvelisib off trial at 25 milligrams twice a day if your doctor can do the paperwork. And I have sometimes used it in combination with romidepsin if I cannot get the patients on a study. So again, this is anecdotal data. There is a phase 1 study of safety with duvelisib and romidepsin, so we know it's safe to give, whether it's going to work in your husband or not. At this point, somebody who's had so many treatments, I treat them as if they have systemic T-cell lymphoma. So they could qualify for trials for systemic T-cell lymphoma at nearby institutions. Most of them will actually take a patient who's had this extensive disease. Other agents that are out there, there are some CAR T trials maybe worth looking into, but I don't know they will take a prior allo patient. Do you know of anything, Dr. Haverkos, that's if he's CD30 positive or he's CD30 negative? So
yeah,
okay, that's
yeah,
an issue.
I think I think duvelisib's, just like Dr. Zain was saying, is something that could be considered. It's obviously still in clinical trials, so I think clinical trial would be the first option if that's an option. But outside the context of a clinical trial, duvelisib plus romidepsin or plus minus romidepsin get a little bit worried about drugs like pembrolizumab in the setting
Right.
of post-allo, but it sounds like the allo has been a while ago, so
Yeah.
that's
6,
certainly
7 years. Yeah.
I think pralatrexate is another drug
Oh,
that
yeah. It doesn't sound like he's had pralatrexate. Exactly.
wasn't on there. So
Yeah.
there's certainly other drugs that are out there that I guess could be considered.
Mhm.
For
I know
clinical trial, be the best option.
there's a couple of trials with EZH2 inhibitors. There is, I know if the CD30, I mean, they should check for CD30 expression again on a repeat biopsy. That's the other thing I would
Yeah,
suggest, because sometimes it can be the expression can be variable. And if it's positive, you could try brentuximab, or there is actually a bispecific, the AFM 113 trial, which is a CD30 bispecific
yeah,
trial. So, yeah.
absolutely. And I think that the thing too that we kind of talked briefly about is brentuximab. Even patients with low level CD30, even sometimes no CD30, can still sometimes
Respond.
respond to brentuximab. So I think that is something to consider in this scenario.
And I've also used bendamustine. So
Oh
that's
yeah.
another drug that I don't see up there. So pralatrexate, bendamustine, these are
Yep.
options. Okay.
Thank you. A derm question for you. Can you comment on the role of sunlight in managing CTCL? Do you recommend it or not, with or without sunscreen? I've heard different things. Thanks for clarifying.
Okay.
I guess sunscreen, yes. So I think we, or at least dermatologists that I work with, we always usually recommend narrowband UVB light. That's a narrow sort of spectrum of light that has less risk of causing other skin cancers. And
Hmm.
so when you just expose yourself to natural light, you get more spectrum of light exposed to it that puts you at higher risk for things like melanoma or other types of skin cancer, which are you know, which we don't want. So I think we always want to do this really in a controlled scenario where we use phototherapy and usually narrowband UVB light. Sometimes we use PUVA as well, but still tend to prefer to use it in the setting of controlled photo booths. We do have a couple of exceptions to the rule where people don't have access for some reason, and we may um, sort of think about a plan that's a little bit outside the box for those patients. But it certainly, if you have access to a photo booth, would recommend doing that.
Agree.
Let's see. I
Okay.
am new to the CTCL diagnosis stage 1, and they started with a 2-week, twice a day betamethasone, then going to twice a targretin. Sorry, is this the safest and best way to start?
Twice a day, targretin tablet. I mean, I always tend to start at a lower dose of targretin just because the side effects. Mostly, you have to monitor for lipid profile and the thyroid function. And again, I work with my dermatologist, and we both feel that a low dose, it can be effective too for a long, and it's better tolerated. The recommended dose is obviously higher, is 300 milligrams per square meter, but 75 twice a day at a total dose of 150 is usually where I start and see how we go. And but that's our practice. It's not, if you look at the prescribing information, which actually I had to do some order sets. It was actually quite confusing because I think bexarotene was developed many years ago without the newer rules about how drugs should be modified. So I think that the dosing is a little bit optimal. Dosing is unclear. I start low and see how the patients tolerate it, and only increase the dose if needed. So I
Yeah,
hope that answers your question.
yeah, no, I think we did the same or had the similar experience to Dr. Zain, that we tried to um, have our own guidelines around using targretin because we're having a lot of community oncologists that were starting at kind of the clinical trial dose, which is basically
Yeah,
double what we usually start at.
yeah, yeah.
And the clinical trials didn't we also usually start people on Synthroid, a thyroid
Right,
medicine, and cholesterol medication, which weren't done sort of preemptively in the initial studies. So I think
right.
we
Yeah.
we've sort of learned from our experience in that and do start it at a lower dose, at least lower than the initial studies.
Yeah. Yeah.
And we have just about 5 minutes left, so time for probably two more questions. I have been under the impression that there was little research on CTCL. After listening, it seems the research and knowledge has come a long way in recent years. Is this correct?
Yes.
Yeah.
Absolutely. Absolutely. Cutaneous lymphomas, it's a rare disease. That's why we don't hear much about it. I mean, compared to breast cancer or lung cancer, is definitely the incidence and the prevalence is much lower. But it is also a disease where there's an unmet need, we call it, because there's a lot of patients who live with this disease. So we want to help them, and we want to have them we want to make sure they have good quality of life. So there is a lot of research going on. And from a scientific perspective, it's an easy disease to study because we can do lots of skin biopsies and we can really apply that knowledge we learn from understanding the tumor environment to other cancers as well, mechanisms of actions and what, figuring out which drugs work where. So there's a lot of work being done in this field.
Which is
Yeah,
very encouraging.
absolutely. It's a good question to have at the end. I think the just the Cutaneous Lymphoma Foundation obviously does a lot to fund some of the research for cutaneous T-cell lymphoma. So
Right.
kudos to the Cutaneous Lymphoma Foundation for supporting it, and I think that's a reason also that we've come so far.
Sure.
So one last question here. It's a little bit of a long background. I am a 70-year-old male diagnosed in 2020 with CTCL, CD30 positive LPD anaplastic large cell lymphoma displaying as facial and scalp lesions or blemishes. I've been on various topical steroids and methotrexate 25 milligrams once per week. These have been marginally successful but needed a prednisone burst, 50 milligrams for 5 days, and then weaned off over 4 weeks to quickly control it. When the prednisone ended, the blemishes returned, done again, and the same results. And then he just asked if there are any other options.
Yes, brentuximab vedotin. We talked about this, and ALCL and LYP. They all express CD30. Again, if it's LYP, usually methotrexate works, or the lesions spontaneously disappear. But if it's getting aggressive and it's really a cosmetic issue and causing symptoms, then certainly brentuximab vedotin would be the best way to treat it. Yeah.
Great. Yep. Well, thank you everybody for joining us. It's about time to wrap up here, and we have a couple people chiming in and just saying thank you to the two of you. We are so grateful for your time and appreciative of your knowledge and expertise. So thank you for spending the evening with us. I did just want to let everybody know that next week on the 28th at 6 o'clock Eastern time, we will be having a panel discussion with our CEO, Susan Thornton, and one of our board members, Michael Young, and they will be talking about Drug Development 101. So some of you may want to attend, might be a exciting and interesting presentation. So please join us. And with that, thank you, everybody. I hope you all have a wonderful evening. And Dr. Haverkos, Dr. Zain, thank you again. Very
Thank
grateful
you.
for you. And
Thank you. Bye-bye.
thank you so much.
Pleasure.
Bye, everybody.
Okay. Bye-bye.